Yeah.
Hello.
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 Good morning.
Hello, everyone. I'm glad to see so many beautiful faces. We're going to start in just a couple more minutes. Hi, Dr. Mitchell. Good to see you.
Hi, how are you, Allison?
Good, thank you.
Hey, Allison.
Good morning. Well, I guess it's afternoon for me.
Good morning, Allison.
Hello. Were you able to see my slides?
Yeah.
Thank you. Thank you. Hi, Jennifer. Are we ready?
Hi there, Allison. Yep, I think we're all set.
I'll wait until it actually goes to 145 and then we'll get rolling.
Yeah, I think so. I think there were probably at least 130, if not more, signed up for this, so we can give it a few.
Okay.
So Jennifer, I'd like to say hello to Dr. Berenberg.
Oh yeah, I saw that Dr. Berenberg was on. Dr. Berenberg? Well, he was on.
All right, everyone. We're at 145, and if there are no objections, I'll go ahead and get started. Thank you so much for joining us today for this wonderful meeting session. I know that we couldn't be there together in person in San Francisco, but we're here now, and maybe the next time we might be together in person. Good to see everyone. This session is going to be pretty wonderful. We're going to give just a really brief update on the Recruitment and Retention Committee and some things that we have going on and that you'll be participating in or seeing in the upcoming months. And then we're going to have a wonderful presentation by Dr. Edith Mitchell. And
Yeah,
then,
Apple ear
and
ones?
then
Yeah.
also, I think someone might not be on mute. And then we're going to have a wonderful panel discussion. So thank you for joining us today. So if everyone can see my screen, I'm going to go ahead and forward my slide. So just a bit of housekeeping. If you don't mind, you can put yourself on mute if you are not already muted, and then we can always unmute as needed. We're going to ask that you put your questions in the chat area, and then we'll address the questions to the panel members and Dr. Mitchell as needed. And we're going to get to as many questions as we can. I think we're definitely an interactive and chatty group. And so we will do our best to get to as many of those questions as possible. So I just wanted to talk a little bit about where we are right now. So diversity, equity, and inclusion, you know, there has been an incredible focus on those issues for the recent. Lucy, can you put yourself on mute, please? Okay. So there's been an incredible focus on diversity, equity, and inclusion, and there have been a number of issues and concerns, happenings in society right now that have really put an incredible spotlight on diversity, equity, and inclusion, including, you know, much of the things that are going on now, such as the trial for the police officer involved in the death of George Floyd, as well as COVID-19 has put an incredible spotlight on how different groups of people are being affected disproportionately by the pandemic. And so it really has, as in the general conversation of our country right now, has really looked at the importance of trust in science and the scientists who are doing the science. It's cast a light on that in a way that has not been there probably. I think it's always been there, but it's put a spotlight on it where it's come to more people's awareness. And we here stand really at the intersection of healthcare and research, and we have an opportunity to have a voice in this discussion and to talk about trust and why it's so important, and how our work in diversity, equity, and inclusion relates to the work that we do. And though we have been talking about it and working in these directions for a long time, our group is now presenting a Take Action series. It's definitely come to our awareness that we're tired of talking about it. We really want to do some things to make a difference in diversity, equity, inclusion, and how it affects us in cancer clinical trials. We believe that diversity, equity, and inclusion and addressing it is good science. And to have a diverse population in our scientific experiments and clinical work is incredibly important, and it helps with the generalizability of our results. The Recruitment and Retention Committee, our mission is to advise leadership on how to recruit and retain minority patients to SWOG trials, and it goes further than that. We also look at how to recruit and retain minority SWOG members and leaders. As important as it is for us to have patients get patient views and viewpoints, it's incredibly important to have a diverse leaders because they are going to be the ones who decide the direction that the science goes and who we we view and who we look at, and what are the priorities in our research. And so diversity, equity, and inclusion reflects one of SWOG's guiding principles, and that's diversity in membership and leadership. And our RRC addresses challenges in recruitment and retention planning generally as well. So while we have a focus on recruitment of minority populations, that is not our only focus. Anytime there are recruitment and retention challenges, we are happy to have input and to work with PIs. One of the things that we've done this year was develop the DIBS committee and the DIBS working group, and that's Diversity, Inclusion, and Belonging Strategic Working Group. And while we're still in developing our mission and vision, we're looking at trying to promote diversity among SWOG members who are at the forefront of this important research that we do. And our vision is for our membership in SWOG to be diverse enough to represent and reflect American society, and for us to be able to support our diverse patient enrollment in clinical trials. So this group is going to be very important in our, it's hoping to be very important in our visioning of diversity, equity, and inclusion in SWOG in the coming years. Another thing that we've done is in response to the Hope Foundation and Genentech, they had a request for proposals regarding diversity, equity, and inclusion. And we were able to get some funding, and we're going to be diving into this right now, which one aspect of the funding is going to be looking at diversity, equity, and inclusion champions. Those will be folks that we will have trained to be available to research committees to help with promoting diversity, equity, and inclusion in their research trials. So we're working on defining those roles and identifying individuals who can be part of that. We are also very fortunate that we got funding to hire a consulting firm, and we have identified one, Pope Consulting, and they're going to be helping us develop the vision for diversity, equity, and inclusion in SWOG for the coming years. So some of you may be involved in interacting with Pope Consulting. They have a background in healthcare consulting and as well as large business firms as well. So we're very excited to have them on board. Another part of the Hope Foundation funding is that we have identified a diversity, equity, and inclusion fellow. And this is Dr. Patricia Robinson from Loyola University Medical Center. And she's going to be working toward helping us improve our diversity and representativeness in SWOG clinical trials. And she's going to be doing research part-time with us, trying to help us better understand and to report our diversity efforts in SWOG. So it's going to be amazing to have her here so that we can, or have her working with us so that we can really dive into the recruitment of diverse populations. I just wanted to give a pitch for this upcoming virtual symposium on May 21st. We are, the Hope Foundation has provided some funding for a virtual symposium that is going to bring together the minority and underserved NCORs, as well as across the NCTN network, including SWOG, Alliance, NRG, ECOG Akron, Children's Oncology Group, and the Canadian Cancer Trials Group. And we're really going to be looking at the real world look at enrolling special populations. And so we're actually having the people who are boots on the ground really having a good discussion about their challenges, their successes, and we're really going to be talking talking and bringing people to the table to discuss this. So there are going to be more details coming, but from this, we're also planning to have opportunities for pilot projects from this symposium. So you'll be hearing more about that in the coming days, really, because I guess we're only about a month away. So now I'm going to segue to our Take Action series. So the Recruitment and Retention Education Working Group, and I want to give a big thanks to Lucy Gansauer and Kamara Mertz Rivera for helping to plan this series. Today we're specifically going to be talking about African Americans and the recruitment and their recruitment into cancer clinical trials. This is going to be a series. This is just one of a series where we're going to be talking about different populations. And so the idea is not for this to be cookie cutter, but for us to really have a discussion about successes and challenges, as well as evidence-based approaches. So each population is unique, and by population, I'm not limiting that to racial and ethnic minorities. I am talking about, various minority groups, including sexual and gender minorities as well. So each population deserves some emphasis, though overall, many techniques that we use may be able to be used in different groups. So for example, doing community outreach, is certainly a technique, but it might have some specific there might be some specific differences when you're approaching certain populations. So we really want to talk about both some of the overarching techniques and methods, as well as specific methods that may work for particular groups. But this is also an opportunity for us to elevate the importance of recruitment as critical to clinical trials. I know that often it's sort of the last thing that's thought about long after the funding has been applied for, long after the grant has been approved. And then we start thinking about recruitment and retention of patients when really that's something that should be done on the front end, and it is important. Your trial won't go forward if you don't have patients in the trial. We're going to be doing a series of these, and this is just the first in the series. So I think now I can stop sharing my screen. I am going to introduce our very illustrious and coveted speaker for today for our series. Dr. Edith Mitchell is an incredibly sought after presenter, and we are so incredibly thrilled to have her with us today to kick off our Take Action series. Dr. Mitchell is board certified in internal medicine and medical oncology, and is a clinical professor in the Department of Medicine and Medical Oncology at Sidney Kimmel Medical College at Thomas Jefferson University, and an associate director for the diversity programs and director of the Center to Eliminate Cancer Disparities for the Sidney Kimmel Cancer Center at Thomas Jefferson University. Dr. Mitchell has spent her medical career helping individuals in medically underserved areas to realize that simple lifestyle changes can have a dramatic impact on cancer care. Through her work, Dr. Mitchell has demonstrated the importance of community service and outreach, especially to those individuals who may not have the means to seek out more conventional medical advice. Dr. Mitchell served as the 116th president of the National Medical Association. And in 2019, Dr. Mitchell began service as a member of the President's Cancer Panel, and in 2020 became a fellow of the Royal College of Physicians. In addition to her medical achievements, Dr. Mitchell is a retired U.S. Air Force Brigadier General, having served as the Air National Guard Assistant to the Command Surgeon for U.S. Transportation Command and Headquarters Air Mobility Command, AMC, based at the Scott Air Force Base in Illinois. I am thrilled to turn things over to Dr. Mitchell, and we're asking that everyone just hold your questions till the end, but feel free to put them in the chat. Dr. Mitchell, thank you so much.
Thank you so much for the invitation to join you at SWOG today. I am so appreciative. And we have worked continuously with a number of the group there, specifically Dr. Paskett, Dr. Barenberg, and Dr. Patricia Robinson, and I have worked together for many, many years. So thank you. Today I will talk about improved survival but continued disparities in cancer, planning the future with precision oncology, but assessing the past through the rearview mirror. I think it's so important that we all understand that we need to look back sometime and give credit to our legacy. The poet James Baldwin said, "Know from whence you came. If you know whence you came, there are absolutely no limitations to where you can go." And I think that's so important for us as we evaluate, and not only evaluate, but determine where we're going in terms of disparities in cancer. Why do we need to know this? Well, there are many factors that affect disparities in cancer, including insurance, guideline adherence, multifactorial issues such as implicit and explicit bias in care delivery, and which I have kind of renamed that it's not implicit bias, it's really institutional racism. And we need to address all of those issues that are related to healthcare delivery, and note that it's time for meaningful, but also actionable change. We've got to make a difference. So my objectives, and just to reiterate that non-Hispanic Black individuals have the highest cancer incidence and mortality rates in this country. And when we think back over how it all started, well, it started prior to that, but certainly we can give credit to the National Cancer Act of December 23rd, 1971, when it was signed by then President Nixon. And that established a number of entities that we work with: the National Cancer Advisory Board, National Cancer Centers Program, the Cooperative Group Program, and SEER was a part of that law. When we think about why is there a disparity in cancer incidence and mortality rates in this country, Dr. Freeman so vividly put this into a perspective in that, yes, we have the gene environment, but there are influences of the gene environment, including social determinants of health and others, and therefore very important for us to address all of the entities from prevention of cancer, early detection, diagnostic procedures, treatment, post-treatment, and survival. So we need to address all of those. And we ask, why do we need to do that, and why now? The AAMC a few years ago produced these data showing that for individuals 18 years and over, 68% were Caucasian, but in those under 18 years, only 56% Caucasians. And it is recognized, there are data now suggesting that by 2050, minority populations will constitute the majority in this country. So one of the areas that we've looked at is the workforce diversity. And what we know is that both African American and Latino populations in this country of practicing clinicians has been stable, has not increased significantly. And what does that mean? Well, African Americans account for approximately 13% of the population, yet only 4.9% of the population of practicing clinicians in the country. So we need to gain more clinicians. This was from the AAMC in 2018, and notice that it was 5.0. And you can see the other proportions of race and ethnicity in the country. So we need to increase the number of practicing clinicians. The ACGME, which most, if not all, practicing clinicians go through at some point, has identified diversity, equity, inclusion, and said the first thing we need to do is contextualize and acknowledge that there is a problem and we need to address it. Accept the issue, develop tools, and tools that are accountable with a focus on the fact that equity matters. They also, ACGME said that we've got to come up with some innovative ideas. And then once we develop these ideas, strategies, and processes, we have to implement them and continuously evaluate. So the ACGME, in support of increasing the diversity of the clinician workforce. And this is just an area to conceptualize that if we talk about inequality, you notice that the tree is bent and apples only growing on one side. So we can go through and say equality, give everybody some help in the same ladders, but still the tree is bent and there are no apples on that side of the tree. When we say equity, well, there are individuals who don't have access to education, etc., and you give them a higher ladder, but there's still no apples growing on that side of the tree, so there's little access. And what we really need is justice. Prop this tree up and make sure it stands up so that there are apples on each side of the tree and that all individuals, regardless of race or ethnicity, have access to the tree, but also access to some apples. So we got to change the system. When one talks about equality and African Americans or others in education in the country, one can only speak about Dr. Jane Cook Wright. Dr. Wright was one of the founding fathers, we were told initially the founding fathers of ASCO, but nobody said that there was a founding mother. And Dr. Jane Cook Wright was the only African American in that group of 7 and the only woman. You can see her with many areas, with Dr. Foti, who is the CEO of AACR. This is her father, who was also Dr. Wright, with former First Lady Eleanor Roosevelt. And this is me here. These are the members of ASCO and the National Medical Association awarding Dr. Wright the Legacy of Life Award. So Dr. Jane Cook Wright was very, very innovative in strategies, and she was the first to show in the laboratory that we needed to focus on tumor cells to help explain the differences in mortality rates of African Americans. Dr. Jane Cook Wright. Now, another event that really affected cancer care in this country was the Medicare bill. Medicare was approved by Congress July 30th, 1965. And at that time, former President Johnson, instead of signing the bill in the Oval Office, as we all see presidents do, he flew to Kansas City, Missouri, and signed it in the Truman Library. Former President Truman was the first president to propose to Congress a bill for health care for the elderly. And with that, that allowed for Medicare as well as Medicaid. How did that affect cancer care? Well, for one thing, all healthcare facilities had to adhere to the Civil Rights Act, which was passed in 1964. And what that said was that any recipients of government resources for healthcare must adhere to the Civil Rights Act. And what that meant were all of the healthcare facilities had to eliminate the signs that said white only and colored on the other side. So that all changed, but it allowed for increasing medical care for those individuals who previously had no access, and access to healthcare, hospitalizations, and overall healthcare rates improved. So Medicare, another entity. For some reason, my slides are not advancing now. Okay, here we go. So I've always been interested in healthcare for African Americans, and this is a study that we did, a comparison of Black and white adults in the United States regarding cancer care and the spending for that. This is for individuals age 40 to 64. Note that private insurance covers 72% and Medicaid 3.5% at the time of this analysis. For Black patients, private insurance covered only 62% and Medicaid covered 21%. So differences in the payment for cancer treatment. For the group over 65, and you would think that everybody has access to Medicare because it's for over 65. Note that Medicare covered 68% for white patients, Medicaid less than 1%, but for Black patients, Medicare covered 51%, and Medicaid still covering almost 15%. So there are differences in access to care based on insurance. However, over this period of time, note that there was a 29% decrease in mortality of cancer in the country over this time period. So very important that cancer mortality rates are decreasing. And you can see the racial and ethnic decrease. Note there's decrease for everybody. However, still African Americans or Blacks account for the greatest mortality from cancer in the country. Therefore, much information and focus on diversity in clinical trials and some of the efforts that have made. First was the NIH Revitalizing Act of 1993, indicating that the sub-analyses are not necessarily statistically different, but they need to be reported in NCI-sponsored clinical trials. This has not occurred in all aspects, and we need to make sure that we emphasize that this should be reported in all cancer clinical trials so that we know differences. And for individuals working with clinical trials supported by other agencies, pharma, etc., we need to ask them to report the differences according to racial and ethnic background. One of the things we note that there is a higher disparity in the South, and that is much less than in the Northeast. And one could say, if you want to change cancer disparities, just move everybody to the Northeast. And we know that's impossible. So we need to figure out for each locality, what are the contributing factors for disparities in various cancers. When we look at breast cancer, note for African Americans that there's a higher mortality rate, advanced stage at the time of diagnosis, and until recently, lower lifetime incidence rates. That has changed. African American women present with breast cancer at a younger age, and there's an increased frequency of adverse tumor features, more polarly differentiated tumors, more triple negative. There's also a higher incidence of male breast cancer. For one study that we did at Jefferson, we looked at the ER positivity in more than 2,000 patients with breast cancer and evaluated the tumors. We found that the histological grade was higher and nuclear grade less than in the Caucasian patients. African American patients had lower ER positivity, but significantly higher Ki67 and P53 expression than the white patients, or tumors from the white patients, and triple negative was much higher in this group. If you evaluate breast cancer by tumor types, note that for hormone responsive and HER2 negative tumors, that African American patients have lower incidence of these tumors with those markers. Yet for triple negative tumors, African Americans have a much higher incidence rate of triple negative breast cancer. It is also recognized that tumors occur in younger age groups who are Black. And for every distribution of tumors according to age distribution, that African American patients have a higher incidence of triple negative breast cancer. Another cancer, multiple myeloma. While many don't describe or even think of multiple myeloma as a disparate cancer, note that incidence of myeloma is more than twice that of other racial and ethnic groups. And mortality, again, twice the number. And that difference, the gap occurs much earlier in life and continues throughout the lifespan of groups that we notice. And mortality rates, again, more than twice the mortality rate of other racial and ethnic groups. And the fact is that MGUS, the preliminary cell, is about 3 times as higher in African Americans. And a lot of studies now focused on what are the contributing factors to MGUS proliferation and eventually multiple myeloma. So a lot of research ongoing there. Colorectal cancer, another, and note that colorectal cancer in individuals over 50 years old, note the decline in the overall incidence and mortality rates. Yet for those aged 20 to 49, there is a continuous increase in the incidence and mortality of colorectal cancer. We recognize that for African Americans, there is a 20% higher incidence rate of colorectal cancer and a 40% higher death rate And in fact, African American men have a 47% higher chance of dying of colorectal cancer than whites in this country. There's much information now on the molecular and genomic aspects of colorectal cancer and division into groups so that we are now evaluating the genomic processes that perhaps contribute to higher incidence and mortality rates. So with all of the cancers, and obviously I can't talk about all of them today, but Precision Medicine Initiative that was started in 2015 has progressed so that we're now looking at the genomic processes that contribute to mortality and higher death rates. One of the areas that I like to talk about is the All of Us program, which was started in 2018 as a part of the NIH program. And this program intends to recruit 1 million individuals from this country, not only those that have demonstrable disease, but normal, healthy individuals can get information on this. And the information from the study is actually given back to the participants so that they can utilize this. At this time, there are approximately 200,000 individuals already participating with the intent of recruiting 1 million and developing a resource of data that will be useful to the individual participant, but also allow for researchers to have a database in order to recruit information for clinical and laboratory research. So a lot of information there. This is a study that is led by ECOG Akron, but SWOG participates in, and that is the MATCH study. MATCH study is still ongoing. The first phase has ended, and this is a study to determine whether matching drugs with targets on the tumor might effectively offer a treatment for patients. And this is just the pathway to entry into the MATCH study. There was a plan for 39 different studies. And at this time, these 4 have already been instituted. So we have information that has actually been reported in the literature. So thank you, SWOG, for participating in the MATCH study. These are some data showing the responses are non-responsive to certain targets. And this was reported October of last year. So it is available. But the purpose was to report some of the earlier data from the MATCH study. The ACA, this was reported in ASCO of 2019, showing that states with Medicaid expansion offered differences in access to care, and that the delay for African American patients was not seen in this study. So Medicaid expansion states showing easier and quicker access to care in individuals, such that we have a lot of areas affecting access to care. And this slide didn't come up as I sent it, but basically for the Sidney Kimmel Cancer Center at Jefferson, we have a focus on populations within our catchment area, and we focus on increasing accrual to those clinical trials. And it wasn't just the clinical trials area. We had community outreach and education for patients and others. There were partnerships developed with churches, with a number of other agencies, with our basic scientists, clinical scientists, and behavioral scientists. We pulled all this information together, and that has certainly affected the accrual of minority patients to clinical trials at Jefferson. So in summary, what we've got to do, it can't be stovepiped. We must have collaboration. And this collaboration that we've had with SWOG has been tremendous over a few years. And therefore, I'm so happy to see SWOG, Alliance, ECOG Akron, NRG, and all of the groups participating such that we're all working in the same direction. So just some summary points on what I've said. Precision medicine initiative, very important for us evaluating the cancer initiatives. As Dr. Freeman said, we've got to work with prevention all the way through survivorship. Cancer death rates continue to decline in the United States, yet there are gaps. And understanding these disparities will help us design the strategies for our initiatives. And that's really important to evaluate what is needed, design and implement the strategies, and then have continuous follow-up and evaluation of what's working. We also should remember the historical contributions to the decline in death rates and understand that. We have a number of initiatives, and the ACA, again, differentially improved African American cancer patients' receipt of timely cancer treatment, reducing racial disparities in access to healthcare. And with that, I thank you again for allowing me this opportunity to speak, and I'm happy to answer any questions.
Thank you, Dr. Mitchell, for that fantastic presentation. If anyone has questions, please place them in the chat, and I will start. Dr. Mitchell, can you talk a little bit more about the concept of justice in the clinical cancer trials and what you see as being some of our, how we should go forward trying to achieve justice?
Certainly. So as I said, what we have to do is make sure we remove some of the challenges, and that has been one, presentation of clinical trials to minority groups. And I am frequently told, well, Black patients don't want to participate in clinical trials, so we don't offer them. Whoa, you know, that means that the tree is bent and there are no apples on it on one side. African Americans want to participate in clinical trials. I talk with them all the time about it. When I was president of the National Medical Association, I had an opportunity to travel all over the country, and I didn't go to any area where the Black patients said, oh no, we don't want to participate in clinical trials. What they said was, we don't trust you. We don't trust the people who present these trials to us. They don't present them in the way that we want to hear about them. So therefore, we need to go to our communities, work with people in the community. We need to get some education on what is important, what do patients want, what actually causes them to be concerned and involved about the clinical trials. So therefore, we need to talk to the communities, get the community agents who understand, people in the neighborhoods, those communities. For example, I was told that Black men did not want to hear about prostate cancer, And yet in a church, this is just one, where I was invited to talk about it, and Jefferson allowed me to do prostate PSA screening and provided the resources. We did all the PSA tests free of charge. We've, in one day, I drew blood on more than 300 Black men who wanted to hear, and of course I didn't draw all the blood. I don't want you to get the idea that I'm taking credit for it. We had nurses from the church who worked at Quest and other hospitals and so forth. They drew the blood. And we provided it to Jefferson, and Jefferson sent me back a report on every patient. And what we found of that 300, I think it was 306 men in one day, they were interested in prostate cancer, and we found 30 or 31 with elevated PSAs, and we gave them a free visit to Jefferson, but also reported that to their primary care physician if it was given. So you see that it's not just one thing. We have to go to the community. If I had asked that 300 people to come downtown to Jefferson, I never would have gotten them. But with the pastor of the church being the first person in line, and others, other important individuals from the community, people that they knew, we were able to get people to roll up their sleeves and allow us to draw blood. So you have to work with the community.
Thank you, Dr. Mitchell. I think you pointed out quite a few important nuggets there, especially going to the community rather than having the community come to the medical center, at least to get that initial, building that initial trust. I had one quick question. The All of Us program, is participation data available yet by race and ethnicity?
It is not given, data are not available yet. We do know the number of individuals who have signed on for participation, and it is the highest percentage accrual of minority or disparate communities that NIH has ever sponsored. So we do have the participation data.
And one other question, does trust depend on the color of the physician for Black patients or other patients of color?
Not at all. We recognize, as I said, 5% for a given year, sometimes below that for African American and Hispanic or Latino physician percentage is a little bit above 5%. It doesn't have to be someone who looks like the participant, but we do have to have people who understand and who can communicate well. And there are data, Allison, showing that some Caucasian or non-Hispanic white physicians spend less time with Black patients than white patients. And these are data that have been substantiated. I think it requires an individual participant clinician to communicate well with the patients. It does not have to be a Black physician, but understand that there are healthcare deserts where there is a lack of healthcare centers and healthcare practitioners in communities, a process probably affected by redlining, that there are deserts, and more physicians will go back to those communities, both Latino physicians as well as African Americans, so that providing access to care is a part of increasing the diversity of the cancer workforce. So that's the important part, that in rural areas and in inner city, there can be deserts where there is a lack of access for healthcare.
Thank you, Dr. Mitchell. All right, we're going to now transition to our panel discussion. So please stay on, Dr. Mitchell. And we have, for our panel, we have Dr. Marvella Ford from the Hollings Cancer Center, Medical University of South Carolina and South Carolina State University, Raymond Obajiran, who is from Baptist Memorial Healthcare Corporation, Baptist Cancer Center, Memphis, Tennessee, and Baptist Mid-South Minority and Underserved NCORE, and Dr. Electra Pasquette from Ohio State University, James Cancer Center, and I'll be moderating our session. We're going to start by I'm just going to start by asking a few questions. And this one is specifically for Dr. Ford, and then we'd like for others to chime in. And again, feel free to put your questions in the chat. Dr. Ford, tell us a little bit about some culturally appropriate approaches to building trust with African-American communities and African-American patients.
Sorry, I didn't realize I was on mute. Could you see the slide that I had up? Just the one slide? Okay, great.
Yes. I saw it a minute ago.
Okay, thank you. I just wanted to share this slide just as to show the conceptual framework. So if we're talking about developing trust, a nice place to start is this conceptual framework that was developed by Dr. Jean Ford and colleagues that really builds on an earlier model that was developed by Swanson and Ward. And this model includes opportunity barriers and facilitators to trial participation, awareness, barriers and facilitators, acceptance, refusal barriers and facilitators, and then moderators, socio-demographic factors, as well as cancer knowledge and education. And so this is where we have a lot of the social determinants of health. And then the success is clinical trial enrollment. So within this framework, we've developed and tested a number of strategies to try to build trust with community members. And one of those is patient navigation. I think Dr. Mitchell just gave a wonderful overview of some of the social determinants of health that could really hinder clinical trial participation. So if people don't have access to the basic life needs, it's going to be difficult for them to make a decision about participating in a trial. We think about Maslow's hierarchy of needs. You know, it's like a triangle, and at the bottom are the things that we need security for life. So if people have housing insecurity or food insecurity, or they don't have a good source of healthcare, it's difficult for them to receive an invitation from a healthcare system to participate in a trial at the healthcare system when they cannot receive healthcare at that healthcare system because they don't have the proper insurance. So when we look at some of the strategies to increase trust, patient navigation is a really excellent one, because patient navigation is really a multifaceted, multi-level approach that has been proven in the literature in many instances to be effective in helping to provide opportunities to participate in trial, to look at people's awareness barriers, making them aware of trials that are open, and then working a lot to help with the cost of trial participation, whether it's scheduling people at a time when they don't have to miss a day of work, or helping with transportation costs to the trial. And then there's trust in the researchers. And I really like the question about whether the researchers have to be from the same racial or ethnic background as the patients. And I think it's helpful, but not necessary. And so the navigators are really a bridge between the patients and the investigators. And so with the navigators, the trust in the researchers can increase because the navigators can help translate the medical information for the patient, but they can also take the patient's concerns to the investigators to help make sure that the patients are being heard and that their questions are being answered in a way that is appropriate and has meaning. So patient navigation is a very good, effective strategy to help to overcome trust barriers. And just quickly, I was going to just use an example where my colleagues and I actually used patient navigation as a way to help overcome some of the barriers to trial participation. And we were looking at underuse of surgical resection for Blacks and whites. We started in South Carolina who had resectable early stage lung cancer because our previous study showed that just being Black and controlling for age and all the other factors, education, health insurance coverage, just being Black meant people were 43% less likely to receive resection surgery than others. And so that led to our R01 trial that ended last year. And I just wanted to show you, we had a really nice schema. We had a usual care group, and then we had a patient navigation group. What happened is after a year, we had only enrolled 20 participants, 20. And so we realized that we needed more, we needed help. And so with the help of Dr. Kate Weaver, we ran the study through the NCORE site at the Wake Forest Research Base. And NCORE is just a tremendous group with Dr. Warda McCaskill-Stevens' leadership in really bringing clinical trials to people in their communities and really helping to build a lot of trust. And so, so here we were at the beginning of the trial, and by the end, this was not quite all of the study data. The trial ended last year, but you can see that we actually met our accrual goal, and it was because of NCORE that we were able to meet our accrual goal. But in terms of building trust, what we found is that we just didn't have enough Black patients with early stage lung cancer, even inside the community cancer centers. So we had to reach out through people who the patients trust, their physicians, their ongoing physicians. So we reached out to patients' primary care physicians. We reached out to their diagnostic radiologists, to lung cancer screening programs. We reached out to community sources of care, federally qualified health centers. We reached out to try to find where Black people in the community were going, what were their trusted sources of care in the community that we could then reach out to and have the patients referred in to the cancer centers. And so we ended up with 22 sites from Delaware to Nevada. And the way the navigators addressed those acceptance refusal barriers was by addressing financial and economic issues and transportation issues. And they helped to explain what lung cancer is and some of the assumptions about it. Like many people felt if you're diagnosed with lung cancer, that's a death sentence. And so the navigators really helped to explain how far clinical care has come, and that now if you're diagnosed with stage 1 through 2 non-small cell lung cancer, your treatment is done with curative intent. We had opportunity barriers for the patients to get into healthcare systems. And then we also worked with insurance companies to help get the patients covered. We spent a lot of time working with transportation. That was even going so far as working with dialysis clinics in rural areas, because most rural areas have dialysis clinics if nothing else. And those dialysis clinics allowed our patients in our study to use their mobile vans to get to the cancer treatment. So the navigators also help to address fear and mistrust and fear of the healthcare institutions. And so because of that, we were able to meet our accrual goal of 200 Black patients with early stage lung cancer. But another type of way to build trust is, again, working with these trusted organizations. I heard Dr. Mitchell mention churches. That's really great. And it's important to bring not only the ministerial leader on board, but also the health ministry members. And so we have another study where we're working with churches in South Carolina, and the African Methodist Episcopal Church actually wrote the Hollings Cancer Center into their 3-year health ministry plan. So we're going out into the community to deliver cancer education monthly using a train the trainer model. And we're also recruiting, we're making the NCORE trials available to the people that we're training with cancer education. And so we're actively recruiting to the NCI's TMIST trial, and we've referred 77 community people to the TMIST coordinator at our Hollings Cancer Center site. Another strategy is cultural competency or cultural humility training. And that's really important, I think, for all staff members to do, maybe on an annual basis or biannual basis, every other year, biennial. We have a cultural humility training program that we lead, and we've led it with research teams at our institution. We did, our group, this recruitment and retention committee actually presented it during a SWOG meeting several years ago. And I think that just being reminded of our own biases, and that we all have them, goes a long way in freeing us to move away from those biases and to embrace diversity. But I think if we pretend we don't have any biases, it's difficult to engage in an open and honest discussion, and I think that's what patients are picking up on. But I think if we're open and honest with ourselves and with them, and approach patients from a perspective of cultural humility and establishing a real relationship with them and recognizing the humanity in them and letting them see the humanity in us, I think that goes a long way to establishing trusted relationships. Thank you.
Dr. Ford, for that presentation. That was great. And we're going to come back to discussion and questions at the end. Next, I'd like to bring up Dr. Raymond Osarajaban, and I may have massacred your name, and so I greatly apologize. And Dr. Rajaban, I'd like to see if you would speak to the importance of the PI's role, the PI leadership in making sure that enrollment of African Americans in clinical trials is successful.
Absolutely. Thank you very much. I would like to share just one slide. I don't know if you can see it. Excellent. So thank you all. I really appreciate the opportunity to participate today, and always a delight to hear Dr. Mitchell, give such a wonderful, panoramic view of the challenge that is cancer care disparities. I certainly would love to address the question and also kind of look at it in a structured way. Dr. Ford and I served on an NCI study section for several years together, and she was always very insistent on conceptual models. So I want to, first of all, just show you this. When we say Black people do not like to participate in clinical trials, what we're actually saying is that we have traditionally failed to enroll Black people into clinical trials. We have to confess that traditionally we had not understood the reason why Black people did not seem to participate in clinical trials. And Joe Unger and Don Hirschman and a number of colleagues in SWOG have done a series of elegant studies that I would strongly advocate that everybody take a look at. These are papers that have been published in the JNCI, JCO, and several others. On this slide, I'm just going to give you the bottom line from an amalgamation of two different publications. So the first one is, when people don't get into clinical trials, where is the barrier? Is it at the individual person level? Is it at the provider level, the clinician level? Is it at the organizational level? Or is it a problem with social policy at the community level? And basically, this pie chart is a distillation of a meta-analysis that Joe Unger did that essentially shows that the reason why 60% of people with cancer fail to get into a clinical trial is because there are no clinical trials available. The reason why another 20% don't get on is because, you know, we, the clinical trialists, designing our clinical trials, set the eligibility criteria too high for people to scale to get into. Basically, asking people to pass through the eye of a needle because clinical trials are the kingdom of heaven. And then you've got the remaining 20% where, yes, there is a clinical trial available. Yes, there is the opportunity to discuss eligibility and chances are you're eligible. And now we're asking the question, will you come on, yes or no? And you can see that the histograms on the right tell you that when you now take that 22% population for whom there is a clinical trial available and they're probably eligible, and then you ask the question, who agrees to get onto the clinical trial on the basis of racial stratification? Suddenly, you see the myth dispelled. When you look at Blacks, Hispanics, Asians, and whites who have gone to a care delivery environment that provides clinical trials, that has providers willing to discuss clinical trials, that has clinical trials that are willing to allow them in by not setting inordinately high barriers to entry, there is really no racial difference. So the challenge then becomes, it is not the patient, it is the people providing care and the environments of care delivery. So when we say Black people don't get into clinical trials, the reason is the environments of care that Black people go often do not provide access to clinical trials. And the clinicians within those environments, and even within environments that have clinical trials, tend not to offer the clinical trials in ways that are acceptable to Black patients. So Dr. Ford mentioned NCORE, and within NCORE are NCORE minority underserved programs. I am the PI of one such program. One of the criteria for entry is you have to enroll a minimum of 30% racial minorities into your clinical trials. My healthcare system with our NCORE program has been able to exceed that very easily. That is not even a barrier at all. So then what's going on to really get to the question that you asked? What is the importance of the PI? What is the importance of the infrastructure that you have? I will back up again and tell you that my healthcare system, Baptist Memorial Healthcare Corporation, is deployed across all of the state of Mississippi, Western Tennessee, Eastern Arkansas, spills over into parts of Southwest Kentucky, parts of Northwest Alabama. Provides 26% of the oncology care in this region that covers 107 counties. And until we got our first NCORE grant, it was a grand total of 0% of our cancer patients who got into clinical trials. So it's easy to say, well, patients in Mississippi and Arkansas and Tennessee don't like to get into clinical trials. But the problem was you weren't creating any infrastructure to provide access to them. So after we brought the NCORE grant and said, okay, here is money from the federal government to build out clinical trials infrastructure to provide access to patients. Then we started having conversations like, why should I put a patient on a clinical trial? Please tell me, what is the importance of this clinical trial? So I had to start doing things like saying 4 tenets. 1, the best treatment is a clinical trial. Discuss, yes or no. And I thought this was a God-given tenet that came from Mount Horeb that everybody understood. But much to my embarrassment, my colleagues stood up and said, no, the best treatment is not a clinical trial. The best treatment is whatever it is that I said the patient should get. So our clinicians are a part of the problem. And we had to go through a process of education to help them understand what is city training, human subjects research. I had questions like, why should I go through this crazy, stupid thing that's time wasting? What is the value of it? So there are all these barriers. We focus on patient level much to our loss. We really need to focus on the provider level and the institutional level. And as a community, we need to create social policies that encourage and incentivize the organizations and the healthcare systems to open clinical trials access, because truly the real barriers are at those levels. The clinicians are not financially incentivized to spend the time to explain the value of a clinical trial. So when you say, oh, I've got a trial for you, and the patient says, look, geez, is this the Tuskegee, syphilis experiment all over again? And then you take that as he doesn't want to go into the clinical trial and I'm going to walk away from it. Well, we all lose. And the reason why that happens, of course, is that clinicians do what they're incentivized to do. So if my RVU system will penalize me for spending extra time to explain what a clinical trial is to a patient and get them on a clinical trial, and oh, by the way, maybe put them on a clinical trial that uses a drug that is maybe somehow directly or indirectly going to cost me money based on my reimbursement model or my payment model, well, guess what I'm going to do? I'm going to find reasons why a clinical trial is not, a good use of my time, the patient's time, or this and that. So one of the things we had to do was we had to convince our healthcare system that the RVU formula for this large group of private practice oncologists in my community healthcare system needed to be reconfigured in such a way that they would be incentivized to support the clinical trials mission. And for me to be able to do that, I had to convince my healthcare system leadership that the clinical trials mission was a very integral part of their mission as a healthcare providing organization, and not because their reward was in heaven because it's the right thing to do, but because it was the financially savvy thing to do, because outcomes were better on clinical trials. And so patients would be more grateful, and you would be able to attract more patients as more and more people are asking, demanding even access to clinical trials. So I don't want to belabor the point today, but I really want to emphasize that pie chart. The place where we have the greatest opportunity is to bring clinical trials infrastructure into the heart of the places where our patients routinely seek care. We have to bring clinical trials to them, not send them to clinical trials. We have to use the model that NCORE and the Minority Underserved NCORE is using, and we have to expand it across the board, because the challenge is not just NCI trials. Joe and colleagues have also demonstrated very clearly that there is a steep difference between Clinical trials accrual into pharma-sponsored trials where barely 2% of such patients are African Americans, and NCI-sponsored trials where about 9% are actually African Americans. Higher, but still not high enough, because 12% of our population of cancer patients are actually African Americans. So even the NCI's achievement is still an underachievement. But we need this framework to be able to teach us where to expend our time and effort if we are going to overcome the barrier. So I'm going to park it there for now.
Thank you so much. And so now we're going to pose a question to Dr. Electra Pasquette. Dr. Pasquette, can you talk a little bit about why it's important to have adequate sample size and accrual goals for African American research patients in terms of trying to create generalizable information for research trials?
Right. So thank you for the question. So I think it's really, really important to be able to answer the question that you're researching in all the populations where it matters. So if you have a study and you recruit 90% whites and 10% blacks, what can you say about your treatment in the black population? You have to present that we included blacks in our study, but that we didn't have enough sample size, a large enough sample size, to be able to say anything specifically to that population. So, if people are writing protocols where they say, we're going to look at the effect of this in black population, and they say that they're going to recruit 20 blacks, which is 20% of their sample size of 100, there's no way they're going to be able to do that. So we have to start thinking a little more about what we say we're going to do and then how we're going to do it. And there are some ways to do that. I'm not insisting that you have to also recruit 100 black patients as well as 100 white patients, but you have to have a good enough sample. It's not just good enough to recruit to the population demographics in the United States of the patients who have that type of cancer, if you want to make a statement about the impact of that treatment in, for example, the black population.
So much. We have a couple of questions in the chat. To the panel, Joe Unger's recent publication shows a decrease in Black enrollment in SWOG trials compared to Kathy Albane's earlier studies. I wonder if the move to personalized oncology trials is proving to be a barrier. And this was from Jeff Berenberg.
Yeah, I can take that. Some of that work I've been privileged to collaborate with Joe on. First of all, the more complex the trials, absolutely, the wider the danger, the greater the danger for disparities. One of our challenges really is to simplify as much as we can our clinical trials, but at the same time, we're obviously driving towards personalized medicine, which will only come through clinical trials. So, like it or not, we have to figure out ways to open access to personalized clinical trials, biomarker-driven clinical trials to patients. Well, the good news is that's not a problem, because if you look at NCI Match, Long Map, which are two large ongoing biomarker-driven clinical trials, a significant proportion of the patients enrolled are racial minorities. I think Dr. McCaskill-Stevens told me as recently as January, over 18% of patients enrolled into NCI Match are actually Blacks. So we must not take the evidence of the existence of a challenge to be evidence of the need to wave a white flag in the face of that challenge. I think what we need to do is understand if this is important enough for us and there is truly a barrier, which of course there is, how do we best overcome the barriers? And the nice thing is that when we take that, that structured approach to understanding where is the barrier, once again, it is never going to be Black patients, poor patients, other kinds of patients, given the option to get a free biomarker test, by the way, which is what a lot of these personalized medicine trials are. They actually give you a test that's worth a few $1,000s. They give it to you for free. That somehow those people would not be interested. Not true. The problem gets back to the places where the patients get their care. Do they care enough to create the infrastructure for access? And do their clinicians care enough? Are they incentivized enough to truly open that access up within their institutions? That's the issue.
Thank you so much. All right, we're going to take one more question out of our chat, and that is from Craig Nichols. Diversity, equity, and inclusion are classic cross-cutting issues, whereas the NCI, NCTN, and much of cancer research is organized in disease-oriented academic silos. Does it make sense to raise the activities and profile of DEI within the existing structures? Or is it better to consider a parallel, newer organizational structure that could interface with these older vertical systems?
What is DEI to begin with? I'm not sure I quite know what DEI means. Is it digital engagement, something?
Diversity, equity, and inclusion.
Ah, thank you.
Hi, this is Marvell. I'm not sure I can completely answer the question, but I think we have some really good organizational structures in place. And, you know, I think layering DEI and the cross-cutting issues on top I think it can be done, but it requires, I think, some training of all of us who are engaged in this endeavor. And you know, I sit on a committee, I won't say which one, and we review proposals, and I won't say where they're from, but we saw a proposal that came through, and the investigators, the question was raised about enrollment of diverse populations into their proposed study, and their response was, well, we have this national person who's going to handle that for us. And so we made the comment, gave it back to the team, and it came back again with the same response. Like, well, we've got this person, and they're gonna take care of that. And so I was telling the team, that's like submitting a proposal without a statistical analysis plan, but saying, we've got this world-renowned biostatistician who will handle it for us. So don't worry, you don't see any analysis plan, and you don't see any sample size calculations or power calculations, but it's okay because we've got this person who's going to handle it for us. And when I said that, I thought, oh, maybe I shouldn't have said anything, because there was like deafening silence. But then one of the members contacted me right after the meeting and said, I'm so glad you said that. And so I think we have the structures in place, but it's a shift in mindset to understand that when we talk about recruitment and retention issues, there's a whole science behind it. And it's not just something that's nice to do or good to do, makes us feel good, or is needed because of to keep our funding. There's already an evidence-based science behind this. And somehow we need to integrate that existing body of evidence into the ongoing discussions and ongoing reviews and ongoing critiques. And these happen on study sections. These happen throughout the spectrum of, I mean, anywhere from writing a proposal, a pilot funding proposal inside of an institution, all the way to P20, P50, U54, whatever the size, the issues remain the same. And I think it's how we respond to those issues that sets the tone for future work. But I don't think the onus should all be on reviewers either. I think within those organizations, making some institutional changes, maybe about the weight by which we evaluate certain factors, might be helpful.
Thank you, Dr. Ford. And I think the last question, a quick one, or hopefully quick, will be to Dr. Pasquette. What are some metrics that all programs should be collecting to evaluate that they're reaching their catchment area?
Right. So I think it's very important that every healthcare institution ask patients to self-report their race and their ethnicity separate. A lot of places still aren't asking. They're looking at people and coding it at registration, and that is not appropriate. So that needs to be done. And then those are the metrics that you then need to check yourself against compared to the metrics in your catchment area, the people in your catchment area who are diagnosed with cancer, the cancer patients who walk through your door, and then those who go on clinical trials, interventional therapeutic, interventional non-therapeutic, etc. But the only way you're going to get accurate data is that you have to mandate it, that the registrars do this on intake for all patients, and it has to be self-reported. It has to be asked correctly, separating race from ethnicity.
Thank you. And so we're coming to the end of our program. Just want to give Dr. Mitchell an opportunity to have a final word before we end.
So thank you so much. And thanks to Dr. Pasquette for telling us what all institutions should do. Another thing that I think is really important, and Dr. Pasquette, if you don't mind that I say, we need to look at our state programs and the state reported data so that we know that we have some tool to compare our own locality to the state, and that's reported for every state. And there is a comparison to national data as well, so that we have something to bring to our institutions regarding what we are facing and what we need to do. And with that, you can frequently get your institution to contribute to the research, to the funding, because it's important for the institution as well. So I would suggest that everybody do what Dr. Pasquette said do, but also obtain your state reports and look at how you're doing as an institution regarding the data that is given for the state and for the nation.
Thank you so much.
So thank you so much for allowing me the opportunity to speak with the group today. And I know that SWOG and ECOG Akron will continue to work together.
Thank you so much, Dr. Mitchell, for and all of our panelists for your wonderful presentations, and thank you for making this a fantastic session. Also, thank you to the Recruitment and Retention Committee. Thank you all so much for sharing with us. So we're at the end. Thank you so much. Have a great day.
Thank you so much. It's a pleasure and an honor to be here. Thank you.
Thank
Great day.
Take
Bye-bye.
care.
So good to
Thanks
see so many
again.
friends. Maybe next time in person.
In person.
Bye,
Take
everyone.
care. Great job, Allison. Appreciate it.
Thank you.
Thank
Thank you,
you.
Margaret.
Thank you so much.